Hi, I'm Brian Lau. I teach with Sports Medicine Acupuncture and with the Sports Medicine Acupuncture Certification Program. I also teach with the 3-day cadaver dissection labs. And a little bit of the dissection is the impetus for why I'm going to do the particular presentation I'm talking about today. So, first off, I want to thank the American Acupuncture Council for having me. And we'll go a little bit into the lung channel and the anatomy. We'll look at some movement aspects of the channel also. So I just finished up two back-to-back 5-day dissections. I do this every year, the first 2 weeks of December with the University of Tampa with the physician assistance program. So I had a lot of opportunity to look internally with the body. We did a lot of external dissection, but we also did evisceration and we went into the abdominal and thoracic cavities. So that's with physician assistance. I'm not really talking much about channels in there. But I'm always thinking about the channels and I'm preparing for when we do dissection for acupuncturists, how to communicate some of this anatomy to acupuncturists. So that'll filter in a little bit to this presentation today. And then we'll go into some application with movement so you can give some patient exercises that will engage the channel, in this case, the lung channel fully. So let's go ahead and go to the presentation and we'll start jumping into the anatomy. So let's get a start. We're just going to go right into the internal pathway. So let me kind of get the setup for this. So let's imagine we're in a prolonged, like a 5-day dissection lab. We'll kind of go briefly layer by layer. So what we have here is on the slide on the left is we have skin on at one portion. We have some subcutaneous fat in this netter illustration, but primarily that's been removed, and we're down to the level of the fascia above the rectus abdominis, the rectus sheath, and the external obliques. So we can see the rectus abdominis underneath this rectus sheath. If I were to look at it from the back surface, that's what we're seeing in the right image. So in this case, we're looking from the back through the body, visceral cavities removed, and we're seeing the peritoneal cavity from the back, but the front surface of it. So here's the rectus abdominis. You can see a window of it. But what I wanted to highlight from this image, first of all, you have the falciform ligament, but another interesting structure is a remnant of the this little ligament, which is the umbilical ligament, which is a remnant from embryological development. And this whole line here is very, very tied in with the linea alba, which is that thick fascial structure that separates the left and the right side of the rectus abdominis. So kind of a nice imprint of the Ren channel or the Renmai. So we'll come back to that a little bit now, but I just wanted to highlight that. Let's go to the next slide. And here in this image, we have the rectus sheath removed from the rectus abdominis. So this is what we would do in dissection is we would start to come underneath this rectus abdominis, just kind of creating a little separation from the rectus abdominis and the tissue underneath, and we would start lifting it up. And that's what we have in this side right here. We have the rectus abdominis starting to be removed, and you can already get a imprint. You can see the peritoneal membrane, the serous membrane, and you can see some of the fascia under the rectus abdominis. The reason I'm going to this detail is when you do this dissection, sometimes it's very adhered. And as you start removing and lifting the rectus abdominis from the pubic bone and lifting it off, it starts to tear the peritoneum because of all the adhesions there. And why would that be so adhered? We have to get into the next layer, which would be the first layer in the visceral cavity and the abdominal cavity. And I'm going to go right to that here. And this is what we would see as we slice that very thin peritoneal membrane. We have the greater omentum and we have the stomach. Hanging off the stomach is that greater omentum. And if everything's moving well on that person before they passed, then you can just easily kind of lift the undersurface of this greater omentum, lift it up. And what you see underneath it is the transverse colon. So it's very, very it's very, very tied into, connected to that greater omentum. So it's connected to the stomach and it's connected to the transverse colon. So that's a lot of anatomy. But I wanted to highlight this anatomy because it gives us really a window into the internal pathway of the lung channel. When we look at the lung channel, we'll kind of look at it now with different eyes. So we'll look at that in just a moment. But I do want to highlight that on many people, when we're doing dissection on many specimens, there's a ton of adhesions. Because one of the things this greater omentum does is it surrounds pathogens. So if you had, perforation, like an ulcer in the colon, it would surround that, and there's a lot of lymphatic tissue in there. There's lymphoid cells that are going to take care of those antigens, or if there is some kind of entry of some pathogen into the peritoneal cavity, that greater omentum can migrate around and surround those areas. So people who've had a history of peritonitis, it's going to be extremely adhered internally, so they don't lift as well, and you can kind of imagine that they wouldn't be able to move as well also. So one more bit of anatomy, and then we'll look at the lung channel, is the greater omentum hangs off the stomach. Let's move up into the thoracic cavity. Oops, wrong direction. And here is the continuation of the stomach, the esophagus, as it passes through the diaphragm. And as I go a little higher up, I get into the trachea and bronchi. And those also are very, very connected with each other. You could dissect them away, but it would take a lot of work. They almost are one unit. So now we have a lot of anatomy to go and look at that internal pathway of the lung channel. So let's look at that. Here it is. So we see these, we study these internal pathways, but it's sometimes not always clear what the anatomy is when we learn them. So we can kind of now see that, yes, we do have these bronchi branching off the trachea. We could follow down the esophagus. We've learned when we learned the internal pathway that the internal lung channel pathway connects to the stomach. It loops down and connects to the large intestine. And that's exactly what the greater omentum does. So what I'm proposing for this internal pathway is we have the trachea and bronchi, the esophagus, the stomach, the greater omentum linking with the large intestine at the transverse colon. So structures match. It matches the description of the internal pathway, but reminding ourselves again that that greater omentum has an immune function, that it has lymphoid cells in there, cells that migrate and take care of pathogens, also links with the actual function of the lungs because they do have a lot to do with Wei Qi. Wei Qi in the surface of the body, well, this is at the surface of the internal abdominal cavity, but still taking some account of the immune response or the Wei Qi response. So function and form both match. I think it's a really good model for understanding the internal anatomy of that internal portion of the lung channel. So let's branch out now to the actual main channel, but we're going to primarily talk about the sinews involved with it, because we're going to look at some movement aspects that I'm going to introduce that can help stretch and open and engage that outer channel, but also engage that inner branch of the channel. So this is what I have as a model and what we teach in sports medicine acupuncture for the lung sinew channel. We have the pectoralis minor, biceps brachii, short head and long head, this bicipital aponeurosis, which is an extension of that, links in with the flexor carpi radialis and then into the thenar muscles. That's the superficial branch. There's also a deep branch of the sinew channel, which is the flexor pollicis longus. Flex is the big thumb. The brachialis, which lies deep to the biceps, a little bit shorter. It doesn't cross the shoulder joint, just crosses the elbow joint. And then that links up with the anterior deltoids and the clavicular head of the pectoralis major. So we also have the scalenes in there, especially the anterior scalenes. I don't have that listed in my list. But there's that superficial branch all the way up into the thumb to the pec minor, and the deeper branch that lies underneath that. The main channel would follow kind of the course, the little spaces between a lot of these muscles. So these could be almost like the river banks, with all the river being the communication that happens in those fascial spaces. A lot of the organisms and such in the river, you could study a river, but you need to understand the river banks, the structures that make up that river, that form that river. And that's what the sinew channel is kind of like. So for the rest of this webinar, I would like to look at a movement a Qigong exercise that I give to patients. I also teach in Qigong classes. And this will exercise that external portion. It'll engage those sinews. But I also want to show how that's going to gently mobilize and move and massage the internal portion, the esophagus, the bronchi, the greater omentum, the stomach. So I think if you want to fully exercise the lung channel, it needs to have all of those components there. And this exercise does that nicely. There's plenty of other good exercises, but I like this one particularly. So this exercise I have on my YouTube channel. I did it a little bit differently when I filmed it originally. I kind of focused a little bit more on the stretching aspect. I'm going to put up another video, same exercise, but I'm going to do it the way I'm showing in this particular webinar. So that should be up soon. But either way, you can kind of check out the video on my YouTube channel if you want to get a reminder of it, or this recording will be available afterwards too if you want to have a reminder for it. So if you used it yourself, great. You have some nice memory aids. But also if you give it to patients, it'll be something you can refer back to. All right, so let's set it up. So this is going to be the exercise. It's a very simple exercise. Anytime we engage this lung channel, we want to engage the sinews, of course, but we also, engaging the sinews will open and close the chest, but we also want to mobilize that internal pathway of the channel. We'll look at that kind of point by point. This is going to be engaging the lung channel, but really when you're engaging channels, you tend to do them in networks. So this will be really the Yang-Ming and Tai-Yin channels as a whole. So that'll be the lung and spleen channel, the large intestine, and the stomach channels. But the primary focus for this one is the lung channel. So we'll come back and look at this video afterwards and highlight some features of it. But let's move on to the next slide. So this is the starting position. This video will loop and you can kind of see it as I'm talking about it. So I'm going to start by bringing the hands up. I'm standing shoulder width stance. My arms are going to cross in front of the body. The forearms are supinated, which means basically the palms are facing me. Our palms are facing the chest. The hands are a little ways away from the body, so the shoulder blades are slightly pronated, and the elbows are slightly lateral to the body. So that's our starting position. I did mention in there that you're standing at shoulder width. This exercise works perfectly well seated if you're working with a patient or yourself and you have mobility issues and aren't able to stand. Even somebody in a wheelchair, when I work with people seated, I have them slide forward, sitting on their sit bones, sitting upright, so they're away from the seat, and their sit bones basically serve as their feet then, so that they're able to have an upright posture in the same way that I have an upright posture in the standing version. Okay. So I'm going to start by opening the chest, which really means that I'm starting to retract the scapula. So the scapula are starting to pull together in the back. You might be able to see that in the mirror that I have behind me, that I'm starting to retract, bring the shoulder blades closer to the spine. I'm opening the elbows while keeping them down. Pronating the forearms. So the pronation will start to stretch the biceps. And at the end of the opening, I'm going to push the hands away from the body so the elbows will be extended, also stretching the biceps. So generally, there's a problem that I see when I give this exercise to people, and I want to highlight what I want to do before I highlight the problem. You'll notice as I'm doing this in the looped kind of version here, is that my hands start narrow or start medial to the elbows, but then they get ahead of the elbows. So that's what I want to do. I want to keep the elbows down, and I want the hands to go wide to the elbows. There's a nice midpoint that you can notice where the hands line up right there. They line up with the elbows just on the side of the body. I'm going to put my cursor over it. So right here. So there's a point in time where the hands, elbows line up, the hands are facing out. This keeps my elbows from going wide. The point is a lot of people are kind of internally rotated in the shoulder. And if they keep their elbows wide, then the arms stay in internal rotation. And I want my arms to externally rotate so that the whole structure opens up. So that's a little landmark you can look for when you're doing it yourself or when you're giving it to patients, is that lining up right lateral to the body, and then the hands continue out. So this is the expansive phase. I'm starting to stretch the biceps. I'm opening the chest by retracting the shoulders in the back, which creates more space in my chest, creates more volume in that whole thoracic cavity. So let's look at the compressive phase of the movement. So once I'm fully open, I'm going to start. You'll see a little gentle contraction in the abdominals, which starts to compress the torso as I fully push out. And that'll take me into a further pronation of the forearms and a winding type motion in the forearms. So let's look at that. So hands push out, turn. So you might be able to see a little better in the mirror, is that the torso bows slightly. My abdomen bows, my spine bows. Look at that a couple more times. So this is where I can start to engage in the front and gently massage that greater omentum. There's a little bit of shortening along the whole front line during the compressive phase, which then when I continue this movement and go into the expansive phase, I'm stretching, compressing, stretching, compressing. So as I turn the forearms, then I'm going to start to reach the arms back. So that's the compressive phase of the movement. And then it returns back to the same position by leading with the fingertips. So fingers come forward. I cross my hands, return, my chest lifts. And that bow that was in the torso kind of unbows, straightens, so I get a nice gentle stretching and mobilization of the inner part of the channel. All right, I'm going to go back a couple slides and I want to look at the full exercise. So hands come up, cross slightly away from the body. Open the hands, expand the chest. Push out, slightly compress. Hands back. Return back to the starting position. Hands out. Push. Compress. Hands back. Return to the starting position. All right. So I'm going to end the PowerPoint. So yeah, very simple exercise. I would highly encourage you to practice it. Like I said, I'll put up a video on my YouTube channel, but this video, I think it has a little snippet of it so you can get the idea of it. But the goal is to open the chest, create more volume in the lungs. But then as I start to compress, everything bows. And then I go back to the expansive phase. So there's movement inside so that I can kind of gently mobilize that greater omentum. I can gently mobilize the stomach. I can gently mobilize the trachea and the esophagus in combination with what I'm doing on the external portion of the lung channel. So the whole channel is active and the whole channel is engaged. So I use this for a lot of different things. You could use it really for anything where you wanted to improve the health of the lung channel. So that could just be preventative, of course. Respiratory issues would be a key component, of course. If you're working with people with respiratory issues, you want them to have that full volume in the chest. Shoulder problems is one that I give this exercise to quite frequently. You have to make sure that there's no pain with doing it. So one component is that turning internal rotation once I've stretched out is I want that to come as much from the body as opposed to all my arm where I'm cranking my shoulder forward. That can create a lot of pain for people who have shoulder problems. So I have to be very gentle. I'm starting from the distal portion, winding my arm, compressing my torso slightly. So it should be very comfortable for people. There shouldn't be any sharp pain with this exercise. But that's one where I give this to is shoulder issues, neck issues, of course, because that shoulder girdle health is very tied to neck pain. So it's really versatile exercise. It's pretty simple. Patients can catch on to it very quickly. They tend to like it because they're sitting so much during the day if they work at a desk or driving, or so many instances where we're compressed there. So it feels really nice to be able to open and stretch the chest and stretch that whole fascial line throughout the arms, but also you get that nice gentle engagement in the inside. So give it a try, see what you think of it. But you can always reference the video and highlight it. And if I have a YouTube video up on it, you can give some questions and comments if you want further clarification. I think that concludes the information I wanted to give today. It's short and sweet. I'm going to put this information together into a longer class that I'll put on Net of Knowledge. It'll be available through LASA and a couple other partners overseas. But that should be coming out fairly soon. I'm going to put a little self-massage in there and some other details for treatment, maybe some needling also. So this was just sort of an introduction, got the ball rolling for that. I was very happy to be able to introduce this to you. And again, thanks to American Acupuncture Council for having me on.